Okay, good afternoon everybody, and thank you for joining us today for our Facebook Live event. I'm Andrew Doe, the Site Manager for Icon Cancer Centre in Mulgrave, and we're joined this afternoon by Icon Radiation Oncologist Dr. Andrew C. Andrew is currently the Clinical Lead for Victoria and Tasmania, and he specialises in the management of urologic malignancies, including prostate cancer. Andrew currently practices at Epworth Icon and has kindly volunteered his time to answer any of your questions, so please don't hesitate in submitting them through the chat. We do have some pre-submitted questions, but firstly, Andrew, let's give the viewers an opportunity to get to know you and tell us a bit about yourself and your background.
Thanks, Andrew. So yes, I'm a radiation oncologist and I work at Icon Epworth. I'm Victorian based and work mainly out of Richmond and Freemasons. My main clinical focus is the management of men with prostate cancer, but I do other things. I have a busy private practice, but also have a strong interest in research, looking at trials that are aimed at improving outcomes for men referred for radiotherapy.
Thanks, Andrew. We might start with one of our pre-submitted questions, and again, please don't hesitate to enter them through the chat. But why are some people recommended watchful waiting and active surveillance instead of other treatments? Shouldn't you just treat the cancer straight away?
Look, that's a very good question, Andrew. When someone's diagnosed with prostate cancer, a number of tests are performed to really get to understand and interrogate what sort of prostate cancer you have. And what we are aware of is that there are many different types of prostate cancer. Some prostate cancers, in fact, are very non-aggressive and sit there, although they grow very slowly over long periods of time. And it may in fact be that these cancers themselves don't require any treatment, and as is often said, you may die one day with, but not from prostate cancer.
Right. And I hear there are a lot of treatment options out there for prostate cancer, so who do I need to see to make sure I'm getting the best treatment?
Very good question. There are many treatments that are available to treat men with prostate cancer. By and large, the two main treatment options include either radical surgery, or some form of radiotherapy, and there's a few other treatment options that are being trialled and considered in the community. And many times, in fact, you have a choice of options, whether you would prefer surgery or radiotherapy. And so what we try to recommend is that someone with the recent diagnosis of prostate cancer is sent to see both a surgeon and also a radiation oncologist to thoroughly discuss each option in detail. Sometimes the treatments are considered to be equivalent in terms of outcome and cure, which is very important. But also each treatments vary quite significantly in terms of what the potential side effects may be in the short and longer term. And it's very important to understand very thoroughly what these side effects may be. And oftentimes the choice then is given back to you to decide.
Just on those treatment options, you did mention there were many, and there are a couple that we hear about in the news and elsewhere. Immunotherapy and hormone treatments. What are your thoughts on when we can utilise each of those?
Well, if we just first talk about immunotherapy, which is a very hot topic of the moment within the oncology domain. Immunotherapy is a form of drug therapy, which isn't chemotherapy, but it's a drug therapy that stimulates the body's immune system to then hope that the body's immunity per se will kill, destroy and find the cancer and eliminate the cancer. And immunotherapy has taken a very front of place position in the management of a number of cancers, such as lung cancer, melanoma, some of the immunologic cancers, for example, as well. In prostate cancer as such, probably the role of immunotherapy is not considered to be mainstream, and certainly not something that we would often recommend, or recommend at all rather, for men with newly diagnosed prostate cancer. And the role of immunotherapy probably is more relegated to men who unfortunately have very advanced disease. And the context of immunotherapy in prostate cancer is still by and large reserved to clinical trials. So there's really no main focus and no mainstream access to immunotherapy at the moment. But this may change, of course. Hormone therapy is an interesting one, and hormone therapy comes into clinical practice in men with prostate cancer in a variety of scenarios. But by and large, what we know is prostate cancer is quite unusual. As a human cancer, prostate cancer appears to feed or grow in the presence of the male hormone testosterone. And so, in fact, if we lower the body's testosterone level, we do see that some prostate cancer cells die. Cancers can shrink. Not all prostate cancer cells will die with hormone therapy. Some will enter a state of quiescence or hibernation. And so we utilise that phenomenon in a number of ways. So hormone therapy can be incorporated as an alternative to any treatment if someone is felt to be perhaps not particularly well, or might be aged or elderly or infirm, and they may have a prostate cancer. We may not necessarily want to cure the cancer, but we want to control it for a period of time, and then we sometimes may use hormone therapy. Now, sometimes hormone therapy is also used in conjunction with radiation therapy, and there are a number of trials that have shown that if you combine the two together, the radiation treatment becomes more effective in the medium and longer term.
Right. So going back to your speciality, radiation oncology, is there anything I can do before the treatment to reduce the impact of side effects?
Well, there are a whole host of things that one can do to minimise side effects, not only just with radiation treatments, but also with surgical treatments. And by and large, it really does pay to try and maintain an optimal level of fitness. We are very much focused on encouraging all our men to lose weight if you are overweight, and that will both help surgical outcomes as well as radiation outcomes. It's also important to try and commit to smoking cessation, as smoking can sometimes heighten the various side effects associated with both surgery and radiation treatment. To eat well, a balanced diet, and minimise consumption of alcohol. So they're the main things that we would focus on, Andrew.
And a bit of a taboo topic here, Andrew, but regarding sexual health, what's the best treatment I want if I want to maintain my sexual health?
Well, look, this can be a very major factor that men take into consideration. What will my sexual health be like after the various treatments? And look, unfortunately, all treatments for prostate cancer can potentially impact sexual health and sexual function for a variety of reasons. Some data might show that some radiation options might be less likely to impact erections and sexual health, but unfortunately, as I said, all treatments can potentially affect this. Radiotherapy, by and large, can affect sexual health by altering and, I suppose, permanently changing or damaging some of the very fine blood vessels that supply the penile bulb. So, if you are sexually active and excited, it can reduce flow to the penis, and that can then impact erections. Now, we spoke briefly before about the usage of hormone therapy, and we also know that if we combine hormone therapy with radiotherapy, then we can have a very significant impact on sexual health, both in terms of the quality of erections and also libido. Now, surgery as well can impact sexual health, and although there are some surgical techniques that can minimise the impact, better described by my very talented urological colleagues, by and large, what they will tell their clients is that sometimes surgery can cut some of the nerves that supply the penile bulb, and so that can unfortunately have an impact on long-term sexual health.
Okay, and I'm sure this is a very common question, but incontinence does come up as a very common side effect. So which type of treatment would be best recommended if you wanted to reduce incontinence?
Yeah, look, I'm very fortunate to work with very gifted urologists at Epworth Icon across the Victorian network where I practice, and my surgical colleagues will always counsel potential patients that surgery can be associated with incontinence, and whereas most men might need to perform pelvic floor exercises and wear pads for the initial period of time after surgery. Usually over time the sphincter recovers and you do become dry. But there are a small percent of men who have surgery who can be incontinent on an ongoing basis, and this can have an impact on their quality of life. But look, fortunately the rates are not particularly high, and there are also additional options that my talented surgical options can offer to improve incontinence, and some of these may require more surgery or minimally invasive techniques. We have procedures that can insert slings, and there are artificial sphincters as well that can be occasionally considered. In my experience though, the rate of incontinence after surgery is quite low. Now with radiotherapy, perhaps we do come out slightly ahead of our surgical colleagues in terms of just looking at incontinence, but you know, then we have other side effects that are unique to us that don't necessarily occur with surgery. But it is certainly not common for men to experience sphincter damage and incontinence after most forms of radiation therapy, but there are some exceptional circumstances where it might be a problem long term, though generally we're not so worried about incontinence within the radiation oncology domain.
Okay. Incontinence is obviously one of the major considerations, but are there any of the other? What are some of the other side effects that patients may encounter with radiation treatment?
Okay. So one of the potential long-term side effects from prostatic radiotherapy is damage to the bowel, and this by and large occurs because the bowel and the prostate are very closely opposed to each other. In fact, they're next door neighbours. And so when you're trying to target a cancer within the prostate that's touching the rectum, you can get a little bit of radiation dose that can irritate the front wall of the rectum. And this is what can sometimes cause temporary bowel problems during the course of radiotherapy. But there are a small number of men who may develop long-term complications. And interestingly, after radiotherapy, these long-term complications may not necessarily manifest for even up to 1 or 2 years, and that's just the unique way that radiation therapy can affect tissues. And probably one of the commonest side effects long term is a condition called radiation proctitis, and this by and large occurs because a small amount of the front wall of the rectum does become fragile and slightly thinned after radiotherapy, and so that bit of bowel can bleed or sometimes cause some mucus discharge. And as I mentioned, it's not day 1, day 2, it's day 200, day 300. So if anyone after radiotherapy develops rectal symptoms, we're very particular with how we would approach that individual, and usually we would send that person to one of our colorectal or gastroenterology colleagues. We'd have to have a thorough inspection of the low bowel just to make sure that the bleeding is not from another serious cause like a cancer of the bowel or a harmless non-related condition like hemorrhoids. And fortunately there are some treatments that can effectively stop the bleeding, and in most instances we can stop it, but not always. Yeah.
Thank you, Andrew, and good afternoon once again, and thank you for joining us for the Facebook Live event on prostate cancer. We're joined again by Dr. Andrew C., Clinical Lead of ICON in Victoria and Tasmania. If you do have any questions, please feel free to use the live chat and enter them in. We'll try and get to them before the end of the session here. Meanwhile, we'll kick along with some of the pre-submitted questions. And moving on from the treatment options and side effects, I'd like to understand a little bit more about some of those future options. So I've heard that stereotactic body radiation therapy can slow down advanced prostate cancer. What's stereotactic body radiation therapy, and where is it available in Australia?
So stereotactic body radiotherapy, or SRS, there are a number of names which encompass this particular treatment, is a fairly new form of radiation treatment delivery, and essentially what it involves is us applying an extremely targeted radiation beam to a tumour in a very accurate manner. And radiation machines that can do this look very similar to a standard radiation machine, but we can flick a switch, if you like, and turn it into surgery mode. And even though the word surgery is within the title, it doesn't involve any cutting or anaesthetic. Now, because we can be extremely accurate with how we administer the dose, what we do is we deliver a higher dose per fraction. And also akin to this, quite commonly stereotactic treatments are shortened. So whereas a typical conventional course of radiotherapy may cover anywhere between 4 and 8 weeks, of the stereotactic treatments can be anywhere as few as 1 treatment up to 5 or occasionally 10 treatments. And we believe that prostate cancer is one of the human cancers that potentially can really benefit from offering this style of treatment. And so it seems to respond very favourably when we offer big doses over a shorter period of time, provided we can be accurate. And so there are a number of trials that are looking at the role of stereotactic radiosurgery in prostate cancer, and there are trials that ranging from looking at offering it in men with newly diagnosed low intermediate risk disease. So the advantages are that we can complete the course anywhere between 1, 5 up to 10 treatments occasionally, and these trials are ongoing, and so we do wait and require a little bit of additional time to really be confident that they may become a standard of care. Now, the second way and role of radiosurgery in the management of men with prostate cancer is when men unfortunately may have developed advanced disease. And specifically what we would then do is target the secondary deposits, or what we call metastases, with stereotactic radiosurgery. And what we've learnt is, in fact, that stereotactic radiosurgery is very, very effective in eliminating secondary deposits of prostate cancer that may have left the pelvis. And we know, unfortunately, that sometimes prostate cancer cells can travel into the bone and spine and also other soft tissue lymph nodes in the body. So where the current focus of interest is men in whom unfortunately have manifested advanced disease, that we can pick off these secondary deposits. And potentially that is a very valuable adjunct or standalone treatment in managing men with advanced disease. And we are very excited about this particular application.
How do I access or enrol to be part of the trials?
Well, Andrew, I hope you never actually have to be considered for a trial, but there are a number of organisations, both academic, public and private facilities within the country. Fortunately, in Australia, most radiation oncology centres peppered around the country have a very strong research profile, and we have very large trialist groups that also allow us to collaborate. So if for whatever reason it so happens that you need to be considered for a trial, then what we would encourage is that you discuss your inquiry with your relevant treating oncologist or urologist or radiation oncologist, and usually they will be able to give you information accordingly.
David, I just thought, just on that track, what other treatment options are being trialled in Australia at the moment, or even the world, if we...
Yeah, well, my medical oncology colleagues are very much overseeing a whole range of trials that are looking at new chemotherapeutic drugs and new what we call anti-androgen tablets, which again, the latter are designed at sort of trying to starve, if you like, the prostate cancer cell from one of its basic food ingredients, testosterone, or a product of testosterone. And there are a number of very exciting trials that have offered and shown significant improvement in outcomes in men who access these tablets. By and large, mainly in men with advanced disease, but also there are trials that are looking at incorporating these drugs in men who present with perhaps high risk but localised disease at that time of diagnosis. There are also some trials looking at a new drug or substance called lutetium, which is a radioactive, if you like, drug that is very clever. It's engineered that once injected intravenously, the drug can find a circulating or resident prostate cancer cell wherever it may be in the body, and then it attaches to that cancer and then administers a payload, which is a radiation dose to kill that particular cancer cell. And there are a number of trials that are looking at the role of this particular treatment for men, primarily with advanced disease, but also looking at men who are being served up for surgery or who present with localised disease.
Great. We've got a question that's submitted about the PSA. I've heard that the PSA is the best way to detect prostate cancer. You can have very low PSA levels when the cancer is aggressive. Is that the understanding? Is that true?
No. So that's true. So this is a very controversial area, but the PSA is a protein as such that you can measure in the blood, and it's used in a number of scenarios. But if you do have an elevated PSA, this could be a sign that you in fact do have prostate cancer. So potentially the PSA can be used as a screening tool, much in the same way as we would use a mammogram to screen women for the potential to have breast cancer. But look, unfortunately, it's not a fail-safe, 100% accurate test, because as you've described, you can potentially have a prostate cancer and not produce PSA, and probably 10 to 15% of prostate cancers don't produce any PSA, and then it does make it very challenging to use this as a screening tool. The other way that we would use PSA is in the context of someone who has a known cancer, who has had treatment for that cancer, whether it be surgery or radiotherapy. Then we use PSA as a marker to follow progress and response to that treatment. So even though it can be an inaccurate test to diagnose cancer, it usually is accurate to follow one's progress and response to treatment. So, for example, if you have surgery, we would expect that your PSA then falls to 0 within 4 to 6 weeks of having your surgical procedure. And if it does fall to 0, that's great, and we would follow and measure your PSA regularly over time. The similar observation occurs with after radiotherapy. If you have radiotherapy, we would expect that the PSA will fall gradually over a period of about 12 to 18 months, and that's one of the differences between surgery and radiotherapy, is that the PSA fall is slow but progressive over a period of time, but still nonetheless gives us great confidence that the cancer is responding nicely to treatment.
Very interesting. What about today? Are there things I can do now to reduce my chance of getting prostate cancer? Any words of advice?
Well, look, as we alluded to before, I think maintaining a healthy lifestyle, maintenance of weight, avoid smoking, excessive alcohol consumption. There are some prostate cancers that can potentially run in families, and so if there is a family history, we do encourage that you see a GP or see a urologist to be assessed and reviewed accordingly. Andrew, you're young, you're fit, you actually belong to an ethnicity that probably also has a low risk of developing a prostate cancer, so I'm pretty comfortable that I'm going to have to see you professionally.
Very good, Andrew. Thanks again for firstly your time and also sharing some of your wisdom and your advice on prostate cancer. Thanks to everybody who joined us for the Facebook Live event, and we'll wrap it up now, and please don't hesitate to contact your local medical professional or ICON if you have any further questions. Thank you.